Good morning. We're here live Friday, 10 a.m. Sorry about the Wednesday thing. We'll get consistent with it, we promise. We're going to talk about disc herniations today and just some of the concerns and fears that many of our patients present with. They'll even call in prior to coming in and seeing us and asking us if we can treat people with disc herniations and what the risk of those kinds of things are. And we'll talk about how you assess it, whether it's even an issue, the fact that it's oftentimes something that is in people that don't have pain, and we probably treat disc herniations all the time and don't know it. We'll talk about some of those studies, and then the reason for disc herniations and why it's our job. What we take our pride in is finding out why the disc herniation is there. We'll talk about some of those factors involved, and if it plays a role in your overall care plan and your treatment plan, as far as whether it's a factor or not. Having come from where I came from in Nebraska Spine Center, which is an orthopedic spine surgery group, I can tell you that disc herniations are very commonplace in patients that go to places like that have been referred out. And I can tell you that I think the biggest thing that I took from that 7-year experience, not only obviously the relationships that I built with those people there, but the fact that I'm not afraid of treating anything, because there's so many other factors that go into people that have disc herniations and the treatment of it, that it's more commonplace than you think, and there's nothing that we can do from a manual standpoint that's going to make disc herniations worse. We'd have to really try hard, and we have to be really sloppy with our techniques, and we'd have to be really careless with what we're doing. And we're not that way here, obviously, and most of the chiropractors out there aren't careless or sloppy with those kinds of things. So disc herniation treatment, and just where I came from, just has given me a lot of confidence that there's really nothing that's going to make you worse from a manual standpoint or from a conservative care standpoint with disc herniations. Dr. Peters is going to talk about some of the research and some of the things that are out there, and I'll kind of expand on some of the studies I think that are really cool, that they just strengthen what we already know. It's not that because of these research studies we change the way we treat things. It's just that it gives us more confidence, and from an education standpoint for you, I think it's important that you hear some of these studies, because it's not just us randomly picking things that support what we do, which we can all do in the research world, but these are some pretty solid studies that aren't in chiropractic literature type of journals, but these are in well-respected spine surgery journals and in physical therapy journals. So these are things that are outside of our profession. And so Dr. Peters is going to hit on some of the prevalence of disc herniations and things like that.
Yeah, so I think, like Corey talked about, is there's a lot of misinformation. We treat disc herniations all the time without knowing it, and what that means is some of these disc herniations, they're present in people without any symptoms at all. A lot of these radiology studies, that's where the literature is coming from, is they'll just MRI thousands and thousands of people, and basically they come and they find all these different significant findings, what you would think were significant, in people with completely no symptoms. And I think that gets back to our body's amazing ability to adapt to things. And what we use these studies for in the office is for patient education, because we're taking a history, and inevitably somebody's like, oh, I have pain at L4, L5. I was like, oh, you have pain there. Why do you say that? Well, I have disc bulges. Okay, well, let's talk about that. So kind of the hallmark of some of the disc bulges is the sciatica, the radiating pain down the leg. And we've even seen it where the patient comes with an MRI, their findings are all on the right, like they have right radiating leg pain, but you look at the image, and the image says it's a left disc bulge. So that stuff like that makes us wonder, makes us question. Our patients are always teaching us things all the time. But one of the things that we do, like that I talked about, is the studies with asymptomatic patients, and you can't really see it all that well, but this is something that we use in the office. I started applying this at the VA hospital when I was doing my internship, because that's a population that they have a lot of imaging, and there's a lot of barriers that you have to break down in patient education. And what we are finding out the more and more that we use these fancy MRI machines and CTs is that these findings are wrinkles that are shown on the inside of the body. So as you age, you get wrinkles on your face. Everybody comes to expect that. Not that we love it, but it happens. So that's what happens on the inside of your body, is that we're going to see more disc degeneration. We're going to see signal loss, height loss, disc bulges, protrusions as you age, and that's completely, it's not significant. It's to be expected. In fact, if you're over the age of 60 or within your 60s, so 60 to 69, disc degeneration is going to be present in 88% of people that don't have any symptoms. So it's there. Like, we know it's there. It's not a surprise. That's one of the. We don't have an X-ray in our office. We use imaging centers around town if we feel like we need to get an image, but we don't feel the need to have X-ray here because a lot of times it's telling us what we already know. Yeah. So we spend so much more time in the assessment is we can almost predict with pretty good accuracy what's going to be shown on the image. So that's kind of the role of imaging at our office. We do use it. A lot of times patients come to us and have already had images, and sometimes that's where we really got to be an advocate and kind of re-educate them on some of the stuff, because you got to understand, in the orthopedic spine world or the orthopedic world, is they use those images pretty exclusively to kind of dictate their treatment sometimes. So we really have to focus on clinically what are you presenting with, recognizing the fact that in people without any symptoms we see a lot of these findings, and correlating that clinically so your image and your clinical exam match up. And this is for the lumbar spine, so the low back. There's studies in the cervical spine, there's studies in the knee, there's studies in professional athletes in the shoulder. So we see it all the time, and sometimes these images can fool us and lead us down this path that we don't need to be on, and it leads to more invasive treatments too soon, generally.
Right.
And that's kind of our problem with it. We always want to start conservative care first, start with chiropractic, because we get a lot of these patients better, and they don't need the fancy MRI, they don't need the injection or whatever.
And Jace brings up a good point about, if you're good with your assessment, he's going to talk about that here after I kind of give you some really cool studies about disc herniations. And if you're good with your assessment, a lot of times you can kind of tell what you're going to see on images for the most part, especially if you kind of correlate it with the patient's age and some of the findings. But for the most part, function, how you move and where you move and things like that, function's always going to precede structure, which means if you catch things early on and you're able to assess functionally, from an assessment standpoint, we look at the function of our patients. We can usually tell, depending on where they're at in that spectrum of their dysfunction, where we're going to see structurally. And so the thing that's problematic is that you'll get an image done, you'll get back pain, you bent over to pick up a pencil, and you'll get back pain, your back went out, which it doesn't really go anywhere. But then you get an image and you'll see a disc herniation, which that may have been there for 20 years before you even had this back pain. And so a lot of times it gives people something to hang on to, and you kind of wear it like a badge and kind of use it as an excuse to not get better and to not do some of the things that you could do functionally to relieve the back pain, and then maybe even make yourself a little bit stronger from like core stability, exercise, respiration, and things like that. The other problem on the other end of the spectrum is you bend over, you pick up something, your back goes out, and you get an image, and there's nothing on the image. Now you're kind of like grasping at straws, and people think maybe it's in your head, or they just kind of get passed along because there's nothing for them to see on an image. So it can work both ways. So I'm going to give you a couple studies here that maybe will make your mind at ease, and then we'll talk about, Dr. Peters talk about the assessment of it, and we'll kind of put a bow on this as far as how we treat and our view of disc herniations here in the office. But I have a couple cool studies. One has 105 workers. These guys work on like assembly lines, and they had no back pain whatsoever, so they did MRIs of all of them, and they had them interpreted by a radiologist that knows nothing about their history or anything like that. These are all relatively younger. I think they're all from 50 and younger. I think the average mean of age was like 42 on these. So of these 105 cases, 55% of those, so a little over 50, had disc alterations. 38% of them had disc bulges, and 17 of them had full-on disc protrusions, meaning the toothpaste was out of the tube, so to speak, and there's a piece of disc just floating around in the canal, in the spinal canal, or in the foramen where the nerve root lives. So that's a pretty significant finding, and these people had no back pain whatsoever, and there's no correlation to future back pain, because the next study was 76 asymptomatic individuals, meaning they had no pain. They did an MRI. They followed these people over a 7-year period, which is a really cool study. It actually is seeing if there's findings that they can see and then predict whether they're going to have back pain in the future. Well, 50 of the people that returned the questionnaires for the full 7 years, 29 of those still had no low back pain. And of those 29, there were 15 of them that had disc alterations on the initial study. So those have absolutely no predictive value whatsoever. 21 of them developed back pain over that 7 years. So of those other 50, 21 of them had back pain. Of those 21, only 12 of those were normal scans at the end of 7 years. So the people that developed back pain, half of those, more than half of those, had normal scans after 7 years even. So only one of them actually had correlative disc findings on MRI and radiating back pain of the remaining, 9 of those patients. So basically what that says is there's no predictive value of future back pain and findings on MRI. This was a really cool study because it covered over 7 years. Another good study is that they've taken MRIs of the cervical spine and had confirmed disc herniations with neck pain and some radiating pain in the arm, and they treated it with manipulation, HVLA, which is high velocity, low amplitude thrusting, which is manipulation for the most part. And they did that over a 3-month period. And at the end of 1 month, 55% of these people had, I think they're 55 of these patients. 1 month, 55% reported improvement, and they have different markers and different stats and tests that they mark improvement on. At 2 months, 68% were improved, and at the end of 3 months, 85% of these people were improved. So that goes to show that you can treat people with disc herniations in the cervical spine, which is always a concern of patients, and see marked improvement over a 3-month period, which is also a very cool study. The last one is your elite athletes, because this is Omaha Spine and Sport. We always want to throw some athletes in there. They looked at 98 elite junior tennis players. The average age was 18 years old. And so these are kids that are playing tennis daily, practicing 2 to 3 hours a day probably. And they found that 62% of these young 18-year-old healthy spines had disc herniations, at least in a mild category. 30% had broad-based disc protrusion, which is a disc herniation, so 30% of those 98 players, and 99% of them had facet or joint changes. So what we're saying is that disc herniations are oftentimes what we call false positives. You have them already, and then regardless of back pain, I could do an MRI, and I'm sure after 43 years of working out and playing college football and things like that, I guarantee I have disc herniations somewhere, cervical spine, low back, if not both. Probably findings in my shoulder for labral tears and those kinds of things. But it doesn't correlate with pain. I don't really have any pain, so to speak. So it's neither predictive, like the size of the disc herniation doesn't correlate with the amount of pain that you have, like they've shown that over and over in studies, and it's neither a prerequisite. You don't have to have a disc herniation to have pain. So these studies just back it up, and there's just mountains of this literature out there. So, if you have had a disc herniation on an MRI, don't hang on to it for a reason to not get better. There's a reason for it to be there, and that's what the assessment usually leads us down. And as far as treatment of it, like we're usually treating in different areas above and below there, because that disc herniation is there because forces are going through it that shouldn't be going through it. So part of our assessment will definitely guide us to the areas that we need to treat, and it's very rarely at that site of disc herniation. So Dr. Peters will talk about what we do from an assessment
So from an assessment standpoint, obviously, if we have radiating pain, we're checking sensation because that's going to kind of lead us down what level can we expect this at, because if a certain nerve is irritated when we have radiating pain, then it leads us down, okay, it's likely in the cervical spine, C5, C6. And that's what Corey's saying, is a lot of times our treatment is actually aimed above and below that, because all those forces where the disc herniation actually happened, it's kind of just the brunt of it, just has to take the brunt of the load. So we need to get a more shared motion throughout the spine. And what we're looking for is a mechanical response. I mean, there's disc herniations that don't respond to what we do, and that's when we're fine, let's refer you out. You might need an injection, you might need a little bit more invasive treatment, but so many do with just a simple movement. So our assessment is looking for those mechanical responders, because that's what are going to respond to what we do. So we're treating the different areas, we're going to move you in different directions, we're going to ask you about certain movements. Does this seem to respond to movements? Is it worse with sitting? Is it better with standing? How does walking feel? So all these are kind of building this clinical picture and telling us, oh, we need to move this patient into extension, and then from that, we will adjust you and manipulate you if you need it in the office, and then send you home with an exercise so we can really speed it up. And I think that's what's different about us. We're not going to bring you back thousands and thousands of times. Like you can self-treat a lot of this stuff just by moving in certain directions, and that's what we find a lot, is that a lot of these respond to mechanical forces. So I think it's a great place to start. We're very, very confident treating disc herniations here at this office. And I think a lot of chiropractors are, and I don't think there's anything to be afraid of from a patient standpoint about that. As long as the treatment plan makes sense to you, we'll continue to be your advocate. That's really what we do here at Omaha Spine and Sport, try to educate our patients, use cool little handouts like this, constantly bringing in the research to back up what we do. And anything else to add?
No, I would just kind of, as far as like the assessment goes, like he said, you're looking for these mechanical responders, but we're also checking like the reason why these forces are going through your disc, because disc herniations, yes, they're commonplace, but they're not normal. Like that's a sign for us that there's too much movement or too much force going through an area that shouldn't be going through there. And the assessment part's going to give us clues as to what parts of the spine aren't working, and that's usually the reason why disc herniations are found. So the most common disc herniation sites in the cervical spine is C5, C6, and the most common site is L4, L5 in the lumbar spine, which are these transitional areas, right above and below these transitional areas. And so a lot of times, to just kind of make an analogy or so that you can kind of understand why we would actually be treating in a different spot, is if you hold a wire and you move that wire back and forth, eventually the top part, right where you're holding it, gets hot and it breaks. That's the reason why disc herniations happen in these common areas, because below there are these really stiff, rigid junctional areas, or above there. In the lumbar spine, it's usually in an area we call the thoracolumbar spine, where it goes from a, actually grab that spine, it goes from a curve, which we call a lordosis, which is an inward curve, to one that's more rounded, or a kyphosis. So the disc herniations are most commonly here in the lower area, because the hips usually are dysfunctional. There's usually a lot of hip flexor tightness or lack of rotation in the hips, so it forces motion through this lower part of your spine. And there's usually a lack of motion up here. So all of these forces from above and below are getting fed into this lower junctional area, and over time it just breaks down the tissues. And so the first tissue to go, because the discs act like shock absorbers and also force transducers. They help move forces from the ground in your body up into the spine. And if there's certain parts of the spine that don't work correctly, then you're going to just chew that area up, and you're going to move excessively through that area, and the tissues can't handle it, and they break down or they bulge. So a lot of times we're treating disc herniations in these spots, like above and below, or here in this area. We're treating usually typically down here when the disc herniation is up in there. And the reason for that is our body is meant to share movement. If I raise my hand over my head and I can't move through my upper back or my lower part of my neck, I either chew my shoulder up, or I'm going to chew my lumbar spine up, or my low back. And that's how this works, is that functionally we have to have shared motion kind of across the spine and the extremities. And when that's not there, then we have things break down, ACLs, labrums of the shoulder, the discs. And our job is to find out functionally where it is you're not moving, regardless of what findings are on MRI. And we have to make that system more ideal so that you can adapt to those changes in a way that's going to spare those areas. And that's kind of a long-winded way of saying that we're treating the functional findings and not the symptoms, even though we're going to do things to help calm the symptom down with directional preference movements, extension, McKenzie type treatments, nerve flossing, soft tissue release if it's an entrapment issue. We're going to treat the symptoms, we're not going to ignore them, but we're going to focus most of our treatment on the reason why those are there, which is usually a lack of motion or too much motion in another area with various other techniques. So we always treat the function, because we know function precedes structure, and that's what we're after. So if you have questions about disc herniations, or you have some fear about seeing somebody in the chiropractic profession about disc herniations, feel free to email us. You can go to our website. There's an email tab on our website. You can ask us questions. We're pretty quick to respond. I share these questions with the guys here in the office, and if I don't have the answer, I'll try to find the answers for you. Or if you just want to call and ask, just call and ask us. We're more than happy to answer questions for you. So we're going to try for 10 o'clock next Wednesday, And do you have anything to finish up with?
No, I think we're good. Next Wednesday.
All right, next Wednesday, 10 a.m. We don't have a topic yet, but we're going to try to get a list so you can kind of know what's going on. We're going to get organized with this eventually.
It's fun. We like it. So
we'll see you next week.